Okay, so we're going to get things underway. So, good morning, afternoon, and evening, everyone, depending upon where you are in the world. So, we are here together apart from around the world. My name is Christopher Simon, and I am the Strategic Advisor for Physician Wellness and Medical Culture at the Canadian Medical Association. And I have both the honor and the privilege of moderating this opening keynote panel of the 2021 International Conference on Physician Health. Welcome. So, speaking of privilege, although we are all attending virtually to this conference from all over the world, I am coming to you from the nation's capital in Ottawa, Canada. In the spirit of reconciliation, it is important in our country to honor the traditional first lands of the First Nations, Métis, and Inuit lands that we are present on. So, I acknowledge the land that I'm coming to you today from is the traditional unceded territory of the Algonquin Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial, and I am grateful for the opportunity to be present in this territory. So our objective here today is to consider the notion of humanity in medicine, what it means, what a profession that nurtures its workforce looks like, and most importantly, how do we get there? So the trouble with anecdotes is they tend to reduce a very complex issue into a narrow experience. But nevertheless, I want to begin with an interaction that I had with my family a few years ago from a patient lens. And this is I was trying to figure out why this came to mind when I was asked to be a part of this panel, and then it dawned on me that the last time that this physician wellness community, international community, was together was at the closing keynote of the 2018 International Conference on Physician Health. And this closing keynote, I was conspicuously absent from because I had to rush home, grab a new flight because my wife had gone into labor. So maybe this is why it sparked the memory for me. So made it to the hospital and in labor with our second child. They called for an epidural. So clearly in a rush, and anesthetist came bursting into the room. They were quite agitated. And as she was preparing for the injection, I kind of pulled her aside and mentioned that my wife was epileptic, and she had a very significant fear of needles and was honestly more anxious about the epidural than the delivery. So interjecting without looking up, she snipped at both of us very sharply that, well, she's just going to have to figure it out, and she doesn't. I don't have time to wait around. We're very busy, and if she wants one, this is her chance. So the epidural went off without a hitch. Everything worked out. I let it go. However, moments later, when they were cleaning up and I think they thought we were out of earshot, I overheard her whispering to the nurse how insane her day had been. They were short-staffed in the ER. There was 3 car accidents that day that of course, taxed them. She hadn't eaten breakfast, lunch, or dinner, and she hadn't peed in hours. So it was in that moment that I saw a person. So does that justify or excuse the tone she took with us? Probably not. But it did give me this sense of compassion and humanity about looking at her in a different light, and I kept replaying that interaction over and over. So I've been part of the physician wellness community for over 15 years, and it is very humbling to know that I still need to be reminded of this and be reminded of what's behind that white coat, and I think we all do. So, considering what the world has experienced through the pandemic and the tremendous stress it has posed on our already strained health workforce, feeling a sense of humanity may be in short supply. So, honestly, I can't think of a more timely and relevant topic to set the stage for what is to come this week. So now, before we get down to things, I do have a few housekeeping items. So we ask that you, I love the conversation going on in the chat right now, but we ask that until the question and answer period, if we can try to keep the chat as clear as possible, just for conference staff and technical issues. The reason being is with this platform, we're actually unable to minimize the ribbon or remove it. So it's just it's kind of distracting for the speakers and myself, and we want to be able to kind of focus on the stories that we're telling. And again, we'll be opening things back up later, and we also need to use it for announcements from conference staff. So thank you. Second, with respect to conflicts of interest, the panelists nor myself have anything to disclose. And finally, speaking of being human, I'm coming to you not only from my dark basement, as sure many of us are today, but I'm mere feet from my 2 kids under the age of 5, one of whom is doing virtual kindergarten amidst our regional pandemic lockdowns. So I I'm not going to apologize for this. We all are used to it by now, but I did just want to explain any errant noises if I'm looking around all of a sudden with bangs going on, or if we get any guest appearances. So in terms of panel format, over the next 90 minutes, the panel is going to be divided into several sections. The first being an opening roundtable, followed by an open discussion, after which we're going to open up the floor to you for Q&A before we conclude. We have a fantastic slate of very patiently waiting panelists, each of whom also happen to be all-around amazing humans, and I encourage you to each check out their full bios through the conference platform. So first up, we have Canada's own Dr. Jane Lemaire, who is a clinical professor in general internal medicine at the Cummings School of Medicine, University of Calgary in Alberta. She loves living near the Rocky Mountains and frequently engages in nature therapy, hiking, skiing, climbing, bird watching with her husband and daughters and son-in-law. So I'm also going to go a little bit rogue and she'll probably get mad at me for saying this, but I'll personally add that Dr. Lemaire is and always has been a long running, well-respected leader and champion for physician wellness in Canada. So we thank her for being here. So next up, we have Professor Michael West, who is a senior visiting fellow at the King's Fund, London, and a professor of organizational psychology at Lancaster University School of Management, where he focuses his work on culture and leadership in organizations, particularly in relation to organization of health services. Professor West was also recently honored as a Commander of the Order of the British Empire for his services to compassion and innovation in the National Health Service. Interestingly, I recently learned too that upon completion of his doctoral work, before starting his career, he worked as a miner. So my interest has been piqued and I want to know more. So, and finally, but no less fantastically, we have Dr. Jen Warren, a mom to Sally and Jack, an anesthetist specializing in intensive care and a para-athlete. So after a tour of Afghanistan serving as a medical officer, she returned home to start anesthetist training when a skiing accident left her with limited mobility. Initially using sport to help her deal with uncertainty, she has gone on to win 18 medals at the Invictus Games, along with her other amazing athletic achievements, all while rebuilding her career as an anesthetist and becoming a mother. She definitely can't say no to a challenge. So again, starting with jumping right into things with round one of the panel, to open things up, Jane, Michael, and Jen are each going to share what humanity and medicine means to them, what role it plays, and what a profession that embraces this could look like. So with that, I'm going to hand things over to Jane. Jane?
Thank you, Chris, and welcome, everyone. So I thought it fitting to take a moment to look up the definition of humanity, since that's what our conference theme is. The Collins English Dictionary defines humanity as the quality of being kind, thoughtful, and sympathetic towards others. And the Oxford English Dictionary, the quality of being kind to people and animals by making sure that they do not suffer more than is necessary. It also adds, humanity is a word for the qualities that make us human, such as the ability to love and to have compassion, to be creative, to not be a robot or alien, and the state of being a person rather than an animal, a machine, or a god. Others define humanity as a virtue, and one that is actually consistent across every culture, and it's linked with the basic ethics of altruism derived from the human condition. And of course, there's a broader definition of humanity, the big one, the human race, and us as human beings collectively. So what does humanity in medicine mean to me? Our role as physicians is to care for the sick and to do so with humanity, as represented in every one of those definitions. Within our profession, humanity is a necessary virtue where we aim to alleviate, or at least lessen suffering, have kindness and compassion for people at their most vulnerable and very often at their worst, emotionally, physically, cognitively, to enact the virtue of humanity without bias, no bias, either innate, learned, conscious, or unconscious. Humanity in medicine compels us to adapt to the needs of our every patient, person, human, and to creatively overcome the substantive barriers to the delivery of care that we face. Humanity in medicine requires us to be healers in the true sense of the word, not robots or aliens where we reflexively and algorithmically apply evidence-based guidelines to the patient, but to consider the patient, person, human, as an individual and address their needs. Humanity in medicine means to not be a god, but to enter into a healing relationship with that person, recognizing the limits to science, but also the very broad scope and the power of healing. So what role does humanity in medicine play in sustaining and nurturing our medical workforce? Well, if we think about how our profession has evolved, in the early days, the doctor-patient relationship was pretty simple because only so much could be offered to ill patients, and there was an acceptance of the ravages of illness, unanticipated tragedies and trauma, the aging body, and there were also traditional gendered roles. A physician devoted time to the profession, while others supported home and family life. But then advances in medical science engendered healthcare systems, and that disrupted the simplicity and also the autonomy of the doctor-patient relationship, and it created workplace tensions that were often beyond our control as physicians. Add in electronic health systems and multiple administrative tasks that just whittle away at our time with patients. Add in profit-driven models of healthcare, the business of medicine, rather than the fundamental right to healthcare, all threats to humanity in medicine. Physicians began to experience occupational distress syndromes such as burnout and increasing threats to our mental health, with emotional distress through vicarious trauma, cumulative moral injury, and often the burden of responsibility for medical errors, adverse events, and simply poor outcomes from really bad disease. So what is lacking here? Humanity. Not lacking from the individual physicians, but from within the culture of our profession of medicine and within our healthcare systems. And yet, somehow, the responsibility for all those system level drivers of being unwell was placed firmly and solely on the shoulders of us as physicians. We were told to be grittier, more resilient, to better tend to our physical and mental health. And for physicians from diverse backgrounds and without traditional home supports, these challenges were actually greatly amplified. Then, of course, mounting evidence supported that unwell physicians affected healthcare systems in terms of poor patient care and cost, and that most of the drivers of burnout originated from the work environment, and thus came the call to action. Physician wellness must be recognized as a missing quality indicator of healthcare systems, and there's a shared responsibility to address physician wellness. That's why we need a system-level approach to physician wellness that's humane. It should assure that physicians have the time, space, and energy to cultivate their own humanity, to not suffer unnecessarily in their work, to not be aliens, robots, animals, machines, or gods, but rather to be able to do their work well, to provide compassionate leadership, and then to pay that humanity forward to our patients, to our colleagues, to our loved ones, and to experience the rewards and joy in medicine. So what is my vision for a medical profession that embraces humanity? My vision is that our profession is to care for humanity and to do so with humanity, to care for the human race through our work in population health, community health. We are in the midst of two of the greatest global health crises we have ever faced during our lifetimes, the COVID-19 pandemic and climate change. I feel that the common foundation for a medical profession that embraces the virtue in medicine is social and racial justice through the principles of equity, diversity, and inclusion. There must be humanity in the provision of healthcare without discrimination or bias based on any cause. For we can only truly care for our patients with humanity when we have empathy for their life situation. And patients can only feel understood when they see themselves represented within our ranks. The pandemic has significantly set back generations of social and racial justice gains for all of humanity, and our profession is no exception. For example, the pandemic has made it much more challenging for physicians with caregiver responsibilities to complete their work duties, and we've seen increased racially motivated attacks on physicians. Humanity in the treatment of physicians must be viewed through the lens of equity, diversity, and inclusion. An understanding that we have to go beyond just simply promoting equity, diversity, and inclusion in the workforce to actively facilitating it, adapting work environments for physicians from diverse backgrounds, and changing our workplace models to accommodate diversity. That will enhance better work-life integration, and our patients may also benefit from more flexible care models. So to close, all of us, as individual physicians, our profession, and our healthcare systems must collectively assume the responsibility for caring for humanity and for ensuring that humanity in the care of our patients, but yes, also in the care of our physicians and the broader medical workforce. So as physicians, let us be aware of and accept our own humanity, recognize the powerful influence and responsibility that we hold as physicians and collectively as a profession to enact the virtue of humanity for every person on this planet, including ourselves. Thank you, Chris.
Wow, thank you, Jane. Thanks for setting the stage for this so eloquently. And there are definitely a few things I want to come back to later, especially the concept of pressure to look at physicians as gods, or as we see in the pandemic, this the hero, kind of the hero label being put, which is obviously from all the best intentions, but some of the other consequences that can have and perpetuating. So I look forward to coming back to it again there, and I also love the historical perspective in terms of bringing it full circle and looking at where we've come. So with that, I'd like to hand things over to Michael. Michael.
Thank you, Chris, and hello everyone, and thank you to ICPH for inviting me to be a part of this panel, and thank you to Jane and Jen for being able to share this with you. It's a huge privilege for me. This last 13 or 14 months has been so difficult for everybody around the world, and I think it's a time for enormous learning for all of us, a time for reflection. For me, the most important learning about this last 13 or 14 months has been the centrality of compassion. I think it's the compassion of health and care staff that has enabled us to cope during this period. Tragically, some of them have given their lives in service of patients and service users. It's been the compassion that staff have shown for each other, and the compassion that our communities have shown, for example, for elderly people living alone. So compassion, I think, is the core message. Compassion is what helps us blur the boundaries between self and other. It enables us to feel a sense of connection, a sense of being supported, a sense of being safe. But what is it? For me to be compassionate to someone who's in pain or fear or distress, I have to do 4 things. I have to attend to them, be present with them. To use Nancy Klein's wonderful phrase, listen with fascination. And then I have to understand the causes of their pain or fear or distress. As Jane says, not by being godlike, but through a dialogue, coming to a shared understanding. And I have to have an empathic feeling response, because that gives me the motivation for the 4th element of compassion, which is helping or serving the other person. And we know that compassion is enormously important in human behavior. Actually, when we ask people to be compassionate, it's associated with the activation of reward centers in the brain, because most of us, the vast majority of us, are hardwired to be altruistic, to help. Because that helping, that compassion is what binds us together as families, as communities. And we know also that compassion is hugely powerful in healthcare, whether it's anaesthetists like Jen visiting patients pre-surgically and being compassionate, and that being then associated with lower requirements for painkillers post-surgically and shorter length of hospital stay, whether it's extra compassion being shown to patients with an early diagnosis of non-small cell lung cancer and the effect on their longevity, being giving them longer, better quality of life, and the effect of clinician compassion in the treatment of chronic health problems like diabetes and HIV, leading to much better adherence, treatment protocols, and much better outcomes, and clinician compassion in the treatment of mental health problems. And we also know that when clinicians are asked to be extra compassionate, let's say over a 14-day period of consultations, it has a significant impact on their own mental health, with lower levels of anxiety and stress and depression. And these effects are truly enormous in terms of the size, greater than the effects of aspirin in the treatment of heart attacks or statins in the 5-year risk of a cardiovascular event. And patients prioritize wanting clinicians who attend, who understand, who empathize, and who help, who are compassionate. How do we create conditions then for our health and care staff to work in compassionate environments? And that's about the culture of our organizations. And every interaction by every one of us every day is an opportunity to shape the culture of our organizations and our teams. How kind we are, how warm we are, how cynical we are, how irritable we are, how compassionate we are, shapes the culture around us. The role of leaders is particularly powerful, because what leaders pay attention to and monitor and talk about, whether it's targets, money, or care quality and compassion, tells us what it is they value. So leaders must embody compassion in their leadership. That means leaders who pay attention to those they lead, who are present with them, who listen to them with fascination. Leaders who seek to understand the challenges that those they lead face, not by imposing some hierarchical understanding from afar, but through a dialogue. And leaders who empathize with those they lead in health and social care. Stress levels, vacancies, intention to quit in many countries are at their highest levels ever amongst health and social care staff. Leader empathy is fundamental. And then leaders who help those they lead by helping to remove the obstacles that get in the way, or ensure that they have, ensure they have the resources they need, the staffing with the right skills, the equipment, the technologies, the training that's needed. And this is not some soft cushion scented candles approach to leadership. I think it requires a great deal more courage than the rather easy opt-out of command and control leadership. It's about being effective as a leader for the communities we serve. It's about, as Jane said, being inclusive as a leader for all we lead. It's about creating collective leadership in this huge workforce, probably the most skilled and motivated anywhere in industry. Why do we manage them? Through command and control. And it's about compassionately leading across boundaries, across teams, across organizations. And it's about understanding what the core needs of those we lead are at work. It's not about putting in place resilience programs and encouraging more mindfulness. Great that those things are, that we need to create humanity and compassion in medicine by understanding and meeting the core needs of health and care staff, by ensuring that we meet their needs for autonomy and control, working in just and fair cultures rather than cultures of fear and blame, that we meet their needs for belonging so that they feel a sense of being valued, respected, and cared for in the teams and organizations they work in. And we meet their needs for a sense of competence or contribution by enabling them to deliver the care quality they aspire to, rather than struggling, always being beleaguered with chronic excessive workloads which damage their health and well-being and care quality. But the most important message that I want to end with is that to create these compassionate cultures, we must all first have the courage to be self-compassionate, the courage to be self-aware in the moment, to understand the challenges that we face as humans, as individuals, as practitioners, to care for ourselves, to empathize with ourselves. After all, we're as deserving of love and attention as every other human being on the planet, and then to take intelligent action to help ourselves, so that we stay close to the core values that give our lives meaning, like wisdom, compassion, and courage. And that enables us then to have deeper and more authentic connections with all of those we serve, all of those we lead, indeed, all of those we interact with. So it begins with the courage of self-compassion. Thank you.
Wow, thank you, Michael. Yeah, I mean, there's so many great things to unpack there. I mean, the one thing that sticks out for me too is the idea of the blurring boundaries between self and other. I think that stuck with me, as well as the idea of that sort of illusion of strength in the whole command and control approach, and how the the real courage may lay in that building that sense of compassion for leaders. So I think that was powerful, and then of course the idea of starting with self-compassion for culture change. So I think those are things I'd like to come back to later as well. So last but certainly not least, I want us to hand things over to Jen, who's going to share her story and her perspectives, and then we will move into our open discussion. So Jen, take it away.
Thank you very much, Chris. And I'd just like to take a moment before I speak just to think about the doctors across the world that are facing enormous challenges this morning, having to go to work under-resourced, without the right equipment, right people. It must be incredibly hard, and I didn't want to speak without just taking a moment to think. But equally, you know, I think it's great to be able to hold these platforms, and I'd like to take both what Jane said, what Michael said, and expand on some of those areas. So, working in healthcare, we're schooled in compassionate care for patients. Compassion is in our core. However, I'd like you to have a think. Look in the mirror or the Zoom screen that we've got in front of us. How often do you actually take the time to be compassionate to your colleagues? And as Michael said, what about self-compassion? And why does this matter? The evidence base is there that compassion is not just good for us, but it also serves our patients. Dr. Chris Turner eloquently demonstrates that civility saves lives. But why is this even a thing? Why do we need to be learning about this in the 21st century? Why is this? It seems such a simple concept. We're compassionate to our core, aren't we? Well, let's take a step back. For those of you who have done as much rehab as me will know this is the necessary reality of making progress. When you went to university for your healthcare course, how often was self-care mentioned? How many lectures covered resilience, team working? I did a very modern medical degree. I went to Manchester University in the UK, and we did problem-based learning. We did communication skills. This was the novel approach. It was all the rage. Self-care, resilience, team working, they weren't actually mentioned. At school, I was told I needed to get good grades. I needed to volunteer. I needed to get work experience. I needed sporting prowess, and I needed a diverse range of
I don't know. Did we lose Jen? Am I the only one that? Yeah. Okay. Well, hopefully we can get Jen back here in a moment. See if anything pops up in the chat if they're trying to reconnect her. So maybe I'll ask the conference staff if they can try to. Oh, there's Jen.
Sorry, I'm so sorry about that. I was muted by the connection gods. So as I said, I went to school. I needed good grades. I needed to be an exceptional student. I then went to medical school. I then needed to create good impressions in order to get the right jobs. I then, once I got into medicine, I needed to do audits, I needed to get certificates, I needed to do courses, I needed to get prizes to be able to pursue the specialty that I wanted. And frankly, I feel exhausted just thinking about it. But surely this makes you resilient, right? Or wrong? Wrong. I think it teaches you about success. It schools perfection. It's an artificial ideal. Failure, oh my goodness, failure. No, we don't talk about failure because that's really bad. But to err is human. But we're humans. Let's look at some fellow humans. Steve Jobs, Oprah Winfrey, J.K. Rowling. If you look at their CVs, yes, the success, but there's also some failure there as well. Medicine, as we've heard, especially at the moment, is tough. It's complex. This is the real world. This isn't a Disney plot. Somewhere in the drive to succeed, the care element is getting lost. And we need to learn as a profession about how to deal with failure. In the UK, the Francis report into mid-staffs and the recent Ockenden report into maternity care are stark lessons in how badly we do failure. Modern care is sometimes getting confused with tests, with interventions, with the latest bit of equipment. Sometimes compassion gets a bit sidelined. How well do we care for patients with medically unexplained symptoms? As an analogy for the type of resilience that we're schooled in, it's like we're going into the mountains in shorts, t-shirt, knowing that a storm's coming. But in the military, from my background, we're told that skin's waterproof. But we're resilient. So look how successful we've been so far. No, we're humans. We suffer hypothermia. We suffer exposure. Why not set off with a backpack with food, shelter, and a mobile phone to call for help? We just don't do this. We've never been taught how to. I get that failure in healthcare is not a good look, but just ignoring it, marginalising it, pretending it's not there, makes it much worse when it does happen. We are humans, just like the patients that we care for. As a wheelchair user, I'm no stranger, sadly, to negative perceptions around my situation at work. A medical student in the UK called Alexandra Lane Adams tweeted very eloquently some of the appalling comments that she'd endured about her disability. Sadly, they're not new to me. I find this so frustrating. I can't sing. I'm rubbish at art, but I don't actually start my CV with these facts. Yes, I acknowledge some of my situations are challenging and I can't just copy what my able-bodied colleagues do. But for me, that's my life. I have to do the school run. I have to parent 2 small children. They don't go, oh no, it's okay, mum, I'll give you a break because you're a wheelchair user. They just behave like any other children. And it's really interesting because I rarely get negativity in first reactions from patients. Why is this? I feel that my visible vulnerability is my strength. And I think that my patients see this too. And let me set the scene by taking another step back, or reflect, maybe using more positive terminology. Year before I graduated in 2003, Dee Burkitt wrote in the Guardian newspaper in the UK about the plight of wheelchair users not getting into medical school. I'm afraid it doesn't read very well. The GMC, our regulatory body in the UK, argued that a shift in public perception of doctors as lifesavers is needed. I'm sorry, but we're not lifesavers, not superhumans. We don't wear our underwear over our trousers. We're humans with an education in healthcare. Thankfully, we moved on for this stance, but I would argue that as a profession, we need to do more. We need to define our profession, not rely on the perceptions of the public perception. Healthcare, sadly, has a really high rate of mental illness and self-harm. And there are considerable resources that have been invested. But I wonder how much of this is because we struggle with the reality of our lifesaver label and do not have coping strategies for actual failure rather than just minor blips along the way. I'm glad that COVID has put the spotlight on well-being and resilience, but it feels a bit like a sticking plaster on a deep wound. Self-care. We're compassionate to our core, so we must be good at this. Well, I'm not sure that I am. I hadn't even heard of this concept until I heard the amazing Sarah Gray talk about the voices in my head. There's a link in the chat. I'd really urge you to listen to her talk. In our healthcare training, I'm going to give another analogy here. Our favourite in medicine, aviation. So the pre-flight brief. So we're instructed to put our own oxygen mask on first. However, in healthcare, our training and lack of self-care directs us to put the entire flight's mask on first. Then apportions blame for our failure due to our lack of resilience. But actually, we're humans. We were just hypoxic. I'd better give you my vision before we take any more steps backwards or I lose my connection again. We need to be brave and vocal. We need to define our profession. We need to passionately pursue diversity and not fear it. Failure should be openly discussed with strategies, coping strategies explored. Self-care needs to be at our core, but it needs to be taught like anatomy and communication skills from medical school with reinforcement during postgraduate education. We need to automatically put on our own oxygen mask first and pack our backpacks for the storm. Humanity in medicine is human beings collectively caring for human beings.
Well, thank you, Jen, and I'm glad we still have you with us, and I'm sure that's something we can all relate to. And it was funny, I was going over the over-under with how many times we'd have to mute or unmute ourselves or remind each other and wait for people to jump back in. So something I think everyone on the call can relate. So thanks for that. We're gonna move over to the open panel discussion, but just briefly on Jen's comments. I mean, one of the things. Well, I'll keep going to see if she rejoins. But one of the things that stuck out for me was that, again, that concept of civility. And, you know, we have a great wellness leader in Canada named Dr. Mike Kaufman. And I don't know if he's the original quoter of this, but I'll quote him anyway. He always talks about how it's okay to disagree, but it's not okay to be disagreeable. And he definitely championed that concept of civility. So I can relate to that. I also like the link of bringing in the concept of learners and looking at what people are coming in with in terms of skills and what people are prepared for right off the bat. And then again, that concept of how do we keep momentum with the spotlight on wellness through the pandemic right now. So with that, I want to move over to the open panel discussion. And to get things off, I actually want to go back to Jen, and I see you've popped back in here, so great. So maybe we'll start with you anyway, it'll be perfect. So to achieve this vision you've kind of laid out here, where do you start? Where do we start?
So I think we need to understand what self-care is. You know, I think there is the vision that we are the lifesavers, we are running to save someone without a thought for ourselves. And yes, that looks good on TV, looks good in the way that you're written about, but actually we are humans living this life. And I think we need to understand how our bodies work, how our brains work. And we need to understand that there are going to be situations that aren't in our control. You know, in medical ethics, there is no right answer for people, and sometimes that can leave us in a very difficult position as a treating doctor. And I feel that if we can understand ourselves and we can know how to look after ourselves, we can recognize early signs of burnout, early signs of trauma, and be able to help ourselves be more effective. And I feel that if we have more compassion, if we're compassionate to our core, then that will then help us serve our patients and enable us to to be more caring. You know, I feel like in the reports that I mentioned that the compassion element is what gets lost, and I feel that's because we're not compassionate to our core. We've got a tough outer cover, we've got some compassion laid on top, but that core self-compassion is lacking.
Thanks. So I mean, I think that definitely has some throughways with what Jane had spoke about, but also Michael. So along those lines, Michael, you know, when you speak of self-compassion as well, and that's what you ended on, you also spoke about the idea of compassionate leadership. So compassion from the other side. So how do you kind of bridge those two? How do you kind of get from that self-compassion to the higher level compassion from leadership?
So I think it's really important that we present the evidence, which shows very clearly that when leaders listen, when they understand the challenges that those they lead face, when they empathize, and when they do the most important task of leadership, which is helping those they lead to do their jobs more effectively by removing the obstacle, helping to remove obstacles, and or helping to ensure the resources, that we know whether you look in actually, if you look in the private sector, you see research over the decades showing that those leadership behaviors are associated with profitability and productivity. Actually, we have 18 years worth of data from over 500,000 respondents every year from our National Health Service in England, from a national staff survey, showing very clearly that those leadership behaviors are associated with improved care quality, higher levels of patient satisfaction, higher levels of staff well-being, better financial performance, and in the acute sector, lower levels of patient mortality. So it's first about presenting the evidence, and then it's about presenting the means by which we can develop compassionate leadership and change cultures. And we are currently working across the NHS, the 4 UK countries, to bring about that change. The Welsh NHS system has embarked on a 10-year strategy to develop compassionate leadership across the whole of health and social care. Similar initiatives are being taken by the government in Scotland, not just in the NHS, but the whole of the public sector. And it's about having the courage to persist in bringing about those changes, so we change the culture. So in effect, we're rewriting the DNA of our organization so that compassion as a value is core, and that those behaviors are manifested and modeled by leaders at every level, from people at the apex of the system to all of those throughout our health and care organizations.
Okay, and I forgot to remind everyone too that we don't have the hand raising functions or any of those fun things too. So we're just going to have people on the panel just jumping in and kind of physically raising their hands to jump in here. So that may be why people are kind of madly waving or trying to jump in. Jane, looks like you wanted to jump in there.
Did you have anything specific you want to ask me, Chris, or just answer that first question about where we go forward from here?
Well, I think one angle I'd like you to kind of talk about is in your opening remarks, you kind of looked at that systems approach. So if we think about where do we start, could you take a look at that systems approach, and where do we start? You know, we've covered the self-compassion. Where do you start with the self? But where do we start beyond leadership and looking at a systems approach?
Yes, and I want to underline what Michael said, is that the physician wellness is now a science. We have evidence. We have plenty of evidence that shows us this isn't just about us all talking about, let's try and be good and feel good and enjoy our work. But there's plenty of evidence and research that supports that physicians are unwell because of the work that they do, that when they're unwell, they negatively affect the health systems that they work in, that it costs the healthcare systems, essentially billions of dollars a year in terms of poor productivity, unnecessary tests, poor adherence to care. Michael really presented a lot of the evidence there. And then the whole idea about leadership. If leadership is compassionate, then we definitely, there's plenty of evidence to support that that's helpful. So in terms of, a systems level approach, it's really time for us to stand up for our science of physician wellness as being integral to patient care. And so whenever I do any physician wellness talks, I talk about the science. And we have an organization within Alberta that does education and tries to help promote how do we get system level physician wellness. And we present ourselves as scientists. We always present the evidence whenever we do talks or lectures or workshops, and we always have content experts speaking. So I think to answer your question specifically, we have to enhance literacy and always bring in the evidence. We have to provide physicians themselves and those in leadership positions with opportunities to reflect. So you present the science and then you challenge. How's that going? How's that going with you as an individual? How's that going within your group? Are you addressing the drivers of physician unwellness? And then we have to start providing systems level opportunities to coach people to change, because this is new. We're starting to understand because of some great papers from our colleagues and great work from people like the people at the Mayo Clinic and at Stanford, the organizational blueprints, the most recent one that outlines the foundational programs that you need to have system level physician wellness enacted. And so I think it's really important you enhance literacy about the science, you provide opportunities for leaders and physicians to reflect, and then you have some experts that can help coach people to start developing and actually operationalizing those foundational programs. And that's where we're at. So things like developing peer support teams, leadership training in compassionate leadership, directly showing the power of the links to wellness. We could go on and on, civility in the workplace and so on, but I think that's where I see the excitement in our science being translated into knowledge and now being translated into actual foundational programs so that we can do the work at the system level.
Jen, you wanted to jump in there?
Yeah, I just wanted to add that, I think this very self-critical, success-based profession that we've joined very much focuses on sort of trying to fix problems, trying to find problems, but equally, I think we also need to look at how we learn as an organization. And there's a great organization called Learning from Excellence, where actually we look at, rather than looking at the problems and trying to fix them, we look at what works and let's expand that, and I think looking at different ways of getting feedback. I recently, with some lovely colleagues at my hospital, undertook an appreciative inquiry. And that we're so in medicine, we're pretty bored of surveys. We get lots of links sent round in communal emails, and it can be quite difficult to engage with them. But this process really helped us to not only listen to what was working, but also then expand that, work on areas that weren't working so well. And I think we need to fundamentally question how we question things. Let's move from a negative, let's fix the problems, rather than let's work out what's working and expand that.
Thanks, Jen. Yeah, I mean, I personally, I love that concept of appreciative inquiry, or that approach that complements the other work out there. Looking at what works and why it works, and helping scale as well. I think that's incredibly valuable as a tool. And I also love the concept of literacy around evidence and research, and looking at that and how we can help ingrain that as a, whether it's as a quality indicator or other methods as well. I think that's a fantastic place to start, and I enjoy that. So now, Michael, I'm curious, looking back, you took a very positive spin in terms of, looking at what we need in terms of self-compassion and compassionate leadership and other concepts. But, looking back at your career, and the kind of the trajectory of all of the experience you've had through the different health systems, and looking at health system change, what is our biggest challenge in making medical training and practice more humane?
I think it's a deeply personal challenge for all of those involved in medicine and medical training from national bodies like the General Medical Council in the United Kingdom through to governmental organizations. I think every individual has to have the courage to recognize that health and happiness are about authentically connecting with ourselves and also with each other, of learning to be present with each other. This principle of connecting with the other person in every interaction that we have, whether it's a patient that we're interacting with, whether it's a colleague, whether it's the person on the checkout counter, of relearning how to be present with each other in that authentic, open, courageous way in the moment. It's not about generating some new muscles of being compassionate. It's about just learning to be present in the moment, to be with the other person authentically, here and now, openly, connecting. Because I think, if we go back to what you were saying, Jane, at the beginning about the challenges that face us, this pandemic, climate change, fundamentally, I think the problems we face as a species is that we have become separated from each other and separated from everything around us. We've stopped recognizing that we are interconnected, that our happiness is dependent on the happiness of every other individual in the world and every other species and our planet itself. And so for me, it's about, at this point in our evolution as a species, when we face existential crises, the like of which we've never faced before, climate change, nuclear weapons, to recognize that our future is about embracing our interconnectedness and having the courage as individuals, first to connect deeply with ourselves, and then to connect deeply with every other individual as a basis for developing our ability to connect with other species and with the planet as a whole.
Sorry, Jen.
Yeah, I would agree with that, and that's why I think our pursuit of diversity within our profession, we need to be aggressive. We need to not only ensure that we represent the community that is our patients, but we need to be able to we need to have a diverse range of views. We don't need to be one schooled brigade that follows a certain set of circumstances. We know that some of the decisions that we make in healthcare, there is no yes, no, black, white answer. And in order to be able to comprehend the full complexities of that, we need to have voices from different areas, from different backgrounds, from different abilities, different cultures. And I think it's an area that sometimes, because medicine is based on ableism, on successfullism, that sometimes we forget that a sort of learned experience, a shared experience, what value that can bring to compassion and care.
Thanks, Jen. And I want to quickly just double click on that concept of equity and diversity, and maybe Jane, I can get you to follow up on that, because I know you mentioned it in your opening remarks as well, and the role that plays. Could you expand on the role that could play, whether it's a challenge or an opportunity?
Well, I've just been listening to both Michael and Jen thing, and it's really thought-provoking, because we all do need to be interconnected, but we're not, because we have our biases. We have our traditional roles that medicine evolved from, and there's so many challenges that face individuals. And for me, we did some work during the pandemic, because many people were feeling the challenges that they were experiencing. And when we put a document together in our Department of Medicine about those challenges, I learned so much about what every individual physician was experiencing. So the inpatient physicians were worried about, contracting COVID. The outpatient physicians were worried about not being able to care for their patients, different types of remuneration. People were losing money. People were asking to do more. People had small children at home, and were trying to, take care of their children while they were doing virtual care. There were people who their academia fell apart. They couldn't recruit patients for their studies. And what struck me was that every person, and I do want to acknowledge people in general, not just physicians, were all suffering through the pandemic, but all the different physicians, there was so much heterogeneity in how they experienced the suffering and the challenges. And I was unaware of a lot of it because I was focused on my role and how it was affecting me. And if we zoom out beyond the pandemic, I really think we have to, first of all, recognize that every person should be able to practice medicine with a career that's adapted to accommodate them, whether that be because of physiological illness, home responsibilities, career stage, whatever. And we don't do that very well. And so just as a very practical suggestion, in our Department of Medicine, we actually crafted a foundation document and said, what are some foundation tenets whereby we should be able to adapt our careers to accommodate that we're people and that we have things happen to our lives, an acute illness, a chronic disability, a change in our life situation. And we set out some tenets to basically say, how do we approach this and embrace this within our Department of Medicine? It shook things up a lot, right? But at least we're at the stage of starting to reflect and at least acknowledge that maybe the person who has a very serious chronic illness, like, I don't know, pick anything, inflammatory bowel disease, can't quite work the same way with someone who doesn't have a significant health issue or someone who's caring for aging parents at home. So I think we can take steps forward, but we have to embrace the fact that we are people and we experience life, and we should be able to have some care models that can accommodate that and still be excellent physicians. And I just want to add one other thing, because I really believe acknowledging many people are not represented in our physician workforce. So there's work in New Zealand where the Maori, they're encouraging, definitely Maoris to be physicians, and same for us in Canada, First Nations to come into the physician workforce, so that when we have our First Nations people come to the hospital, they see faces and there's a culture that's represented that's makes sense for them. I just think that inclusion is so important, and we have to continue to take baby steps forward.
So,
Oh, Michael, you're on mute.
just to add, Chris, that for me, inclusion and compassion are twin. They're two sides of the same hand, because they're about blurring the boundaries between self and other. It's about a sense of belonging. And we know that inclusion and exclusion and discrimination are health issues, that the pandemic has demonstrated what we already knew, that when we exclude people and discriminate against people on the basis of their bodies or their ethnicity or their nationality or their gender or their age or their socioeconomic background, we damage their health and well-being. Whether, children excluded from friendship groups in the playground, we know it has health consequences. So inclusion is a health issue. It's also a performance issue. Diverse teams with positive climates are much more innovative and productive and effective than more homogenous teams at every level of organizations. This is really, really clear. So it's a moral issue, it's a performance issue, it's a health issue. And given the learning from the pandemic about the disproportionate impact of the virus on people who are discriminated against in society, and now is the moment, I think, when we must make a commitment to really transforming our cultures to be inclusive in the future, and stop scratching around the edges about, simply making sure we've got better diverse board representation, or we're managing disciplinary procedures more effectively. It has to be a wholesale culture change. And now is the moment in health and social care, so that our health and social care systems offer a model for the rest of society, that we can become, as a species, inclusive, creating a sense of belonging and value and love for all. It is possible. There are places that have achieved this, and now is the moment to bring about this change.
Thanks. Jen?
Yeah, and I'd also like to echo that. And I think particularly when diversity and inclusion are considered, sometimes it's very easy to get defensive and think, well, I'm not discriminatory, I don't do this. But I'd like to turn that on its head and say, what have you done to be inclusive? It's not about what you're not, it's what you are doing. And I think that's really important in how we make progress. Because I think seeing this concept of seeing things from different angles, I can remember vividly as a young general duties medical officer telling somebody who was a physical training instructor that he was going to need 8 weeks off because of his knee injury. And I can remember I still cringe inside when I think how flippantly I said, yes, just 8 weeks, what's the matter? And then subsequently having an injury of my own and remembering how much I hung on to every single appointment for making progress, for getting back to work, for like I'm utterly mortified at my previous self. And I didn't do anything wrong. I was caring and compassionate towards that patient. However, I fundamentally didn't understand what I was saying. And I think this is why it's really important to have diversity.
Yes, we can and must do better. Okay, Jane, so I know you're a very glass half full kind of person, so I want to kind of pose this one to you. I'm curious, in all the chaos that we've seen in the last year and other parts of the world, I'm curious what trend makes you feel optimistic that we are heading in the right direction. What are the signs? What's out there that's telling you that we are taking steps, that it's not just looking at the forest through the trees, towards realizing this vision for humanity and medicine? And I'll cue the other panelists too, because I'd like to hear their thoughts on this as well.
Well, I think it's just really exciting for all of us in our wellness group, because we've been at this for 15 years, but we know it takes a really long time for culture change to happen, so that's okay. And in the early days, people politely rolled their eyes at me and said, "Oh, Jane, it's so good you're doing that touchy-feely, physician wellness work." But those very same people now are so supportive and so on board. So I'm excited because we have science, the evidence to show that what we do, to understand what we do. And now we're starting to make change at the system level. And I have to say, I knew that we were having impact. And the pandemic actually, the one nice thing about the pandemic is it helped to give me perspective. So the first thing was that as we started our pandemic planning, we were invited to the table. Physician wellness was invited to the table of pandemic planning as not just physician safety, but physician wellness. And through all our pandemic planning documents, it was integrated throughout. How do we make sure there are psychological supports in place? How do we up titrate our availability? How do we do some workshops? How do we up train some more peer supporters, et cetera, et cetera? And we've been so grateful to see that it is ingrained in our system and our culture to some extent, because we were asked to be represented at the table. And then the second thing is that we've increasingly, and in particular during the pandemic, seen that compassionate leadership come through, Michael, to your point. And we talk about that a lot. And we've watched leaders, start out with, "Hi, everyone. We know this is a really hard time. We know you might not be doing okay," and end with, "Stay well. You need to take care of yourself. This is a marathon." And in every communication, there was some bit of compassion from our leaders that told them that they understood we were people and that this was a hard time. And I think that was just really it lightened my heart. And then also when we had issues and we went to leaders that I wasn't sure how they'd respond, they actually stopped and thought and recognized that we had to change certain things because of the stresses of the pandemic and because what was happening to the physician workforce. And I'm not sure that that would have been the response 15 years ago. It would have been, you know, suck it up and you guys are tough and you just need to make this happen. We've also been able to accelerate some of our promotion of, you know, helping people develop system level foundation programs. So the pandemic has kind of given us an extra boost in what I see is, you know, a really successful and progressive work towards really ingraining system level physician wellness. So I'm very optimistic. And I want to thank everyone for all the work they've done before to provide all that evidence so that we can go in there with our science to make our case.
Thanks. Jen or Michael, if you want to add anything to that. Michael, you're on mute. You're unmuted there. So
everywhere I go in health and social care systems and in different countries, I hear of a thirst for compassion and compassionate leadership. I'm also encouraged by system level change. I had the privilege 2 years ago, of co-chairing an inquiry into the health and well-being of doctors and medical students across the United Kingdom. It was commissioned by the General Medical Council, who were very supportive, and there was international support for the work we were doing. It's called Caring for Doctors, Caring for Patients, and it presented, if you like, a model for how we can meet the core needs of doctors and medical students at work, so they are able to be their best selves, to be as happy as they can be at work. And we found so many wonderful examples of organizations that were creating the conditions where they were providing high quality, continually improving and compassionate care for patients by providing high quality, continually improving and compassionate support for staff. Northumbria National Health Service Trust, the early stages of the pandemic when there was no PPE equipment, built a factory, hired local cutters and sewers and produced 2.5 million gowns for the organization and for other healthcare organizations across the country. They formed a community bank to provide loans for staff whose partners had lost their jobs so that they wouldn't have to go to payday loan companies. And there are many examples across every health and care system where compassion is being embodied, and this wave, this movement towards greater compassion and humanity is breaking. But I think what's important is, for me, not simply to be optimistic, but I find that I'm able to be hopeful when I persist myself in taking action and have the courage to keep going in seeking to bring about change, because I think that culture change, as I said earlier, every interaction by every one of us every day is an opportunity to shape the cultures of our teams and organizations. And we must have the courage and the authenticity to persist in continuing to take action to bring about change, to create more compassionate, inclusive, collective cultures.
Well, I'd just like to echo what Michael and Jane said, and also to say that, you know, I think until 2020, well-being was seen as something the weak few needed, something that was a nice to have, but not a core part of our practice. And I feel that the pandemic has brought it into stark reality that well-being needs to be something that we all do. Self-care needs to be something we all do. And for us to be able to deliver high quality, compassionate care to all, we need to be compassionate from inside to out.
Okay, thank you. So before we move into the Q&A, there's one theme that was brought up consistently that I wanted to toss out there to anyone on the panel, and just quickly touch on any thoughts you may have. It's the concept of looking at the learner segment, so students and residents and medical training, and the role that all this plays in terms of promoting humanity. You know, Jen, you spoke a little bit about the training context in terms of, you know, recruitment and looking at the qualities that people are looking for, and maybe focusing more on the academic side, not so much on other things, looking at failure. You know, and I couldn't help think about the whole like concept of, you know, compassion and culture change and promoting self-compassion, and what role that maybe people play and the profession plays in terms of building and helping promote these concepts within the learner segments as well, to help jumpstart and starting from the top and starting from the bottom and working the way and meeting in the middle. So I'll toss out there as just an open question to anyone on the panel.
I'm happy to kick off, Chris, by saying that the review by Tresiak and Mazzarelli, Compassionomics, showed that in 17 out of 18 studies, compassion declined during medical training, and that's a really disturbing finding. And yet all of the evidence is, when we select for and develop compassion in people, that they're well able to learn how to be more compassionate. It's simply reinforcing what's a natural hardwired orientation in us anyway. And also the evidence shows that the supervisors of people in training play a key role in modeling compassion and helping to develop compassion.
I'd like to add to what Michael said, that hidden curriculum. First of all, we need to have zero tolerance to incivility, abuse of learners. We need to look at our service models where we rely so heavily on learners, and have non-teaching models that allow us to cap our teaching and our education units, so that we're not just adding more and more work to learners that's totally unrealistic. So we have to set boundaries on work expectations, just as we do for us as staff on the learners. Zero tolerance to harassment and incivility. And then people that are supervising learners who are identified as, you know, being unprofessional, they need to be removed from those settings. And I think we just have to be really more aggressive in setting boundaries around that. And lastly, just role modeling. So when we start doing our wellness work, when I sit with my team at the beginning of a week, you know, expectations, well, call me if patients are sick, and, you know, blah, blah, blah. And then I say, and you all get to eat, drink, and go to the bathroom every day. And in fact, you need to take time for lunch. And if you're having a really like chaotic time and your head is all crazy, take a time out, go sit out in front of the hospital for 5 minutes. In Canadian winters, that doesn't always work very well, but, you know, just having those little nature breaks. And we actually role model. I'll tell them I'm going to my office, I need a little break, and make sure that they realize that that's an important part of their sustaining themselves as professionals.
Yeah, and I'd also like to just say, let's give the students the tools they need from the start. So, you know, just like at university, we learn about communication skills. You know, we think, yes, we've got into university, our communication skills must be fine, but we've learned that actually if we teach people how to communicate, they do it better. And it's like, why aren't we doing this about self-care? Why aren't we helping people to understand how they respond to situations, what they do when they're stressed? And certainly I found that when I faced my injury, I just carried on doing what I'd done to solve every problem in the past. So every problem in the past had been solved by me just working harder. And I approached my problem by working harder. And unfortunately, I had an injury that wasn't rehabable, so I didn't get any better. And then, because I had this very critical inner voice, I just spiraled into despair, because I just had no other coping mechanism other than work and physical activity, neither of which I could do, that helped. And I sort of had to hit bottom before I was able to sort of Many people did try and help me along the way, but I was pretty stubborn. So, it took some time, and it's just a shame, because I just feel like if we give people the tools from the start in order to have different coping mechanisms, recognize what they can do, recognize their stresses, recognize their abilities to manage situations, and we can help prevent these kind of deep declines, because we will face issues. There will be unexpected things that happen. Yes, this pandemic has brought things to the forefront, but who knows what's going to be in the next 5 years.
Okay, thanks. And sorry, I still want to leave a little bit of room for questions. We have about 8 minutes left for that. So, Jane, I'm guessing that that your response may tie into the first question that we have, but I'm going to ask everyone if they have a question, that we're going to try to get to a couple at least, and if you don't get them answered, there's going to be lots of opportunities to keep the conversation going forward through the conference platform. So apologies in advance to anyone we can't get to. Please post your questions. I have some moderators standing by who are kind of feeding me. So if you see me looking around, I'm looking at the different messages I have up here. So we're going to spend about 8 minutes doing this, and then we're going to come back and wrap things up. So the first one is still along the same lines of the education piece. So what are some practical ways, maybe Jane, will start with you, what are some practical ways to help practicing physicians feel safe through, whether it's through the undergraduate medical education curriculum, in terms of coming forward with struggles and being comfortable reaching out for help within the education training system?
Yeah, so I mean, it relates to setting a culture and a workplace where it's not shame, blame, where it's the idea that it's okay to sometimes be unwell, and it's absolutely imperative that you report if you're experiencing discrimination and harassment from any cause. And I think this ties into the last point that I really did want to make, is that we need to also start educating now that there's a difference between occupational distress syndromes like burnout and mental illness like depression, anxiety, whatever it is. Because a lot of people now they feel that they can say, I'm burned out, because that's somehow a little bit more socially acceptable, but there's still a huge stigma against talking about mental illness. And I know that Mike Myers is watching here today, one of our preeminent experts on physicians who died by suicide. And we know that physicians have undiagnosed and untreated mental illness. And that may be one of the reasons that we have such high rates of death by suicide in our profession. So stigma, 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 breaking down stigma, telling people, making it safe for people to report. But we also have to have system level places where people can report, and then we have to have systems in place where we act upon those reports. And because if people often feel like, I report this discrimination, harassment, nothing ever happens, and now all of a sudden I'm in a position of perhaps retribution from superiors or losing licenses, etc. So I think it's all about, we have to establish safe working environments, zero tolerance for discrimination and harassment, places to report, and then action within the system to have some results when a complaint is launched. And then recognizing that we are all people, we suffer from mental illness, and it's okay to seek help if that's happening to you.
Thank you. Jen, I have a practical question for you that's been getting some love in the chat here. So, what's your favorite technique for supporting others who are looking to deal with failure? Failure was something that you brought up in your notes, and that's something people are curious about.
Sorry, you just broke up as you asked that question. Do you mind just repeating?
Sure. So, what's your favorite technique for supporting someone in terms of managing or dealing with failure?
So, I think that managing failure. So, we need to be taught that failure is part of being a human. It's not a negative, complete it's not a dirty little secret kind of thing. It's something that we have as humans. We need to create safe systems that keep patients safe, but we also need to recognize that we are humans operating within that space, and that we are perfectionists, that we are driven to get things right all the time, but perfectionism is rarely achieved. And I think helping people understand that that yes, something has happened, but I think in days gone by, incidents would happen in the hospital, and through shame, through lack of awareness that this could happen to other patients, these were kept quiet. Patients weren't told, families weren't told, and I think that culture of denial and silence is incredibly damaging. And even though it's hard, we need to be brave. We need to say, look, I'm sorry, we got this wrong. And that in itself is a more positive way. Yes, you can't change what's happened. You can't change the failure that has happened. But you can change how your organization learns from it and help prevent that failure from reoccurring to other patients or other systems. And it's difficult, it's uncomfortable. We are a caring profession. We don't go to work to do a bad job. We go to work to care for our patients. But I think it's so important to recognize that we are humans, and we need to have strategies for coping when things don't go to plan. But those strategies need to be learned in advance. They can't just be in the moment. They need to be learned from an earlier stage, from the start of our training.
Thanks, Jen. So the next question, and this may be the last one before we have to kind of conclude for closing remarks, but and it's something that I'm sure all of us will like to comment on, but I'm going to start with Michael at least and see where we can get. How do I convince my organization to prioritize this, whether it's compassion or wellness in general? What is it? You've spoke a little bit about the evidence, the evidence base, the importance of promoting that, but what else can we focus on?
The evidence is overwhelming, Chris, in terms of the links between physician wellness and indeed the wellness of all healthcare staff. The evidence is overwhelming that that's what predicts quality of care, financial performance, staff well-being, staff retention, and in the acute sector, patient mortality, patient satisfaction. And what's happened in recent years is we've seen, because of the chronic excessive workloads that staff are dealing with, that healthcare staff are leaving. Our systems are hemorrhaging healthcare staff, whether it's general practitioners, primary care physicians, or doctors in secondary care. And so there's a huge shortage of staff around the world, and the intention to quit of staff is steadily increasing, and absenteeism because of sickness as a result of chronic excessive workloads are going up. So the case from an organizational performance perspective is fundamental. And if we want to continue to deliver high quality, compassionate care for the people of the communities we serve, then this is not some additional luxury option in the way that we run our organizations. This is fundamental, because we will lose the battle for retaining our staff in our communities and countries if we don't care for the health and well-being of our physicians, and we will not be providing the quality of care to the communities we serve. So it's absolutely fundamental.
Thank you. Jane, I can feel you wanted to jump in on this from several time zones away. So I'll give you the last word on this question for maybe 20 seconds if you have it.
Oh, thank you. I was just excited about everything Michael was saying. How do you convince your leadership? So present the science, and then ask for engaging your leadership. Sometimes they'll say, okay, you can make a wellness group and go at it. And you say, no, we need a formal title, a formal position, some funding, some protected time. And when we start to do things like physician wellness measurements for departments or group, we say, we'll do it, but you have to be part of it. You as a leader have to promote it for us. You have to be there when we present the results. You have to be there when we sit with your group and show the results and talk about what you're going to focus on to make better, so that you're engaging physicians at the grassroots level, but you're expecting leaders to be part of it. And then there's a ripple effect, because one set of leaders say, we did this peer support team, we did some physician wellness measurement, and then other leaders hear about it. And it's quite amazing that these networks start and that the ripple effect can be really positive. So engaging leadership, formalizing wellness, not off the side of your desk, asking, demanding that, it's for real. It's just as important as that research team or that, medical education team. And then, we've been very grateful to have our physician leaders recognize the importance and making sure that this is ingrained in the system. And then the physicians at the grassroots, they'll be engaged, because we are the ones who know the solutions, and we are the ones who can move this forward. We have the power.
Okay, thank you. So we only have a couple minutes left here, and I wanted to have just a few closing remarks. Now, I would like each of Jen, Jane, and Michael. And Jen, I'm going to start with you. I was going to ask you to kind of give your elevator pitch for everything we've been speaking about, but I'm going to condense it down to one word. I'm going to throw a curveball at you. So, if you had to sum up your key message into one word or a couple words in terms of what you want people to take away, what would it be, Jen?
Self-care. Learn about it, do it, practice it.
Michael?
You're on mute, Michael.
Almost made it.
Love and connect with oneself and all others.
Thank you. And Jane?
Fundamental to the system and needs to be recognized at the system level.
Thank you. So I mean, there's so many key messages that we can take, including the concept of the impact on patient care. I mean, for me, the whole idea of compassion really stuck out for me, whether it's self-compassion or compassionate leadership, and looking at those different segments as well. So I want to take the opportunity to thank the BMA and the ICPH program planning committee, as well as the conference staff for herding all the cats behind the scenes, and finally to Jane, Jen, and Michael for being fantastic panelists, for being human, for sharing their expertise. I was searching for a closing anecdote or some really powerful, meaningful philosopher that said some really eloquent thing about compassion. And I was racking my brain for over a week looking in, and at the end of the day, it came down to a kid's show that many of us will all remember, and Mr. Rogers' Neighborhood. So I think I want to end with in the spirit of the whole day and the immortal words that Mr. Rogers always tell us: be kind to yourselves and each other. So thank you very much, and all the best for the rest of the conference. So at this time, I invite users to leave using the leave button at the top right-hand page and spend the next few minutes before the next session taking a break, visiting posters, exhibitions, and chatting with colleagues. So thank you, everyone.